yeah, it's a very quick and dirty introduction to the health and retirement study, which is humongous, as they say, and it keeps getting larger all the time. And so what I tried to do, I looked at the conceptual framework of the EMOT-ECON and tried to pick out the different sections that you might be interested in using and as we move along, right? And also some that maybe are linked to the FAMNET. Okay, so this is an outline of what I will try to get through today. So we'll start off with an overview, a very quick overview of what's the design of the health and retirement study. It's a longitudinal panel. How does that panel evolve? And a sort of quick overview of the content. I can't do the whole content because it would take weeks anyway. And so I've selected some content that's probably relevant to the people who are doing research in EMOT-ECON and FAMNET, at least from what I could see on the website. So talk a little bit about all the data that we have on economic status and the sort of financial burden that people have. I added in health because that's actually very important. Also a predictor in terms of emotional well-being, social connections, also linked to emotional well-being. I call them individual characteristics. You have, I think, a lot of aspects in terms of sort of the personal characteristics, the beliefs of individuals, how they appraise situations, and maybe how they cope with different life challenges. Emotional well-being, of course, we have quite a bit of data there too. Quality of life, primarily we have a lot about life satisfaction. We also have quite a lot of biomarkers that are available to be used, and of course the demographics. And then at the end I'll go through how on earth do you have access to these data? Where can you find them? And what do you have to do to get started on your analyses or writing a paper? Okay, so a quick overview of HRS. It's actually the largest and the most comprehensive, nationally representative, multidisciplinary panel study of the US population over age 50. So you will find some younger people in the when you download and you look at the sample. In part, that's because we sample by households, and we interview both people, both the target individual and also their spouse or partner within that household. So some spouses or partners are younger, some older, of course, but on the most part they're younger. And we follow people from the time that they actually enter the study until we find either they tell us don't ever come back and bother us again, or until we know that they're no longer alive. It's funded by very generously by the National Institute on Aging, but also by the Social Security. So that's how we link to a lot of information about pensions and things like that. Okay, so it began in 1992. And it's always been based at the University of Michigan. It started just with one birth cohort, and these were people born between 1931 and 1941. And then we've followed those people through over time, and new every 6 years, new birth cohorts are introduced. And they're sort of between the ages of 51 and 56, as well as their partners. So we do biannual core interviews in even numbered years. So 2022, we're in the field currently. and mail surveys sent out to people in the odd numbered years. So as you might imagine, that generates a lot of data along the way. And each biennial wave since 1998 includes about 20,000 people or so from around the US. Not, we don't go to Hawaii or to Alaska. There are interviewers based in every state, so I'll tell you a bit about that now. So, so in general, in the data set, you have currently around 43,000 respondents have ever been interviewed. Okay, so this is probably a very busy overview of the entire panel. So this is the original cohort that I mentioned that came in 1992. So it was initially funded, it was sort of to see, can we actually do this, right? From with the funding from NIA. And then at that point in time, there was a lot of interest in the oldest old. And so in 93, they recruited the so-called AHEAD. Don't worry about all of these different acronyms, but they were all born prior to 1924. And so we followed those people over time too. So then it was sort of in the, we were both interviewing this cohort, but also bring in the oldest old as well. And this was a function of the interests of the director of NIA at that point in time, Richard Sussman. So we continue with those two cohorts until 1998, when the idea was, let's pick up all the cohorts. Let's make it representative of the population over age 50 in the US. So that's when the so-called war babies came in, people born during the Second World War years. They call them the children of the Great Depression. So they were born in between, after this very first cohort and this cohort. So and so you had a complete panel, and that idea has been continued over time. So you'll see some papers in the literature that only follow the original cohort, because obviously they've been followed for a very long time. And you can see many people moving into retirement, starting to have more health difficulties, many of those sorts of things. But in addition, from this design, because new birth cohorts are added every 6 years, some people want to look at the early 50s in 1992 versus what a new cohort looked like in 98 versus 2004, when the early baby boomers, that's EBB, first came in 2010, when the mid-baby boomers joined, in 2016, when the late baby boomers, and by then we've got all the baby boomers. That's a very large chunk of the US population. And now we're up to the so-called early Gen X. I don't know if anybody is in that birth cohort yet, but we keep on adding, right? So that's a sort of interesting phenomenon too, because obviously different aspects of healthcare have arisen in these different historical periods, right? And different historical events clearly as well, right? Okay, so that's another sort of design that you might want to take along. However, I think most people here are interested in looking at the psychosocial measures in terms of well-being, and also linking perhaps to some biomarkers. And so this was a big change that occurred 2006. It was initiated. And I've circled here, put together the 2008. So what, in order to collect biomarkers and physical measures, instead of just having self-reports of weight, height, those sorts of things, we need to go into the field. And so this is where from 2006 onward, a rotating random 50% of the panel are interviewed face-to-face in the biennial wave every 2 years. And at that point in time, they also receive the psychosocial questionnaire. So there was a huge increase in the amount of data that happens here. So this is where 50% of the panel are interviewed over the telephone. It's a computer-assisted interview. And the other 50% are interviewed in person with an interviewer actually entering the house and interviewing both partners, but putting the responses into the laptop and bringing them back. Okay, and that's continued over the years, maybe not in 2020, which I'll tell you a bit about in the future. But part of the beauty about this is that you could, in essence, you could put both of these, or either you can use it as a replication sample, given that it's randomly selected, or you can add them together so you have a much larger panel along the way. Okay, so this is now starting in 2006, and I know it looks complicated, but basically this was when we first started this 50-50, and they also provided saliva, and that saliva has all been genotyped. So we have 2.5 million SNPs of the genome from this group. And the same happened here when the new mid-baby boomers came in. And then in 2016, it got bigger and better again because they put in an expanded cognitive battery, but also people were signed up, or if they agreed, if they consented to provide some venous blood and to visit a clinic to provide that. Pandemic, of course, interrupted everything. We went back to straight telephone and mail surveys, and now we're trying to catch up again with those sorts of things. Okay, that's a quick overview, but I think it's important to realize different ways will provide you with different pieces of information. Okay, so now I'm just going to do a quick overview of what we have in the variables that I think are probably relevant to the model that you want to look at in terms of EMOT-ECON. So I'll go through each of these circles and provide you with some information. And this is the website where you can find lots of more and more information, but I will lead you through that a bit later. So let's think about economic status. So the study began really with economists and demographers and some health professionals. So we have a lot of information about employment and pensions and insurance and income and wealth. Takes quite a chunk of the interview each wave. But it's actually really valuable. So if you're thinking about work, now people, of course, enter this study and they're still in the workforce. Not everybody is, obviously. but we know their job title, what industry they're in, how many hours they worked, whether they're full and part-time, all of these sorts of things. And these can all be linked to ONET and a lot of additional information. And we know when they retire. So there's more questions then about satisfaction in retirement. And now these days we know people unretire. So go back, and then what job do they go back into? There's a lot of information about pensions or lack of pensions, Social Security, all that sort of thing. Different aspects of insurance, especially health insurance, having access to that, obviously the cost of healthcare if they don't have health insurance. Many questions to enable you to calculate their income and also their wealth. But if you like me, I just cheat, and that's in 2 sections in HRS. I'll explain these sections in the next step. But if you like me, I'm not an economist. I'm not going to go to the effort of putting all of these separate variables together. But there's a cooperative agreement with RAND in Santa Monica, and they produce very nice composites of, for example, the total household income or the individual's income, putting a mass of variables all together, the total wealth of an individual, the total out-of-pocket medical expenditures. So these are things that you could look at in terms of the burden in terms of medical costs and things like that. Of course, if you want to put them together yourself, you can. But and some people, of course, have zero wealth because they've got a big mortgage or they're in debt or whatever, right? But nevertheless, you can look at these composite scores. RAND has lots of explanation about how they make them, and you can decide if you would like to use that. In addition, RAND is sort of responsible for a mail survey called CAMS, Consumption Activity Mail Survey, that goes in the odd years. And that's about it goes out every October, every 2 years, and that's like what do you spend your money on, basically. And again, it's a self-report. In addition, we have self-reported information about, like, if people say, that they're feeling emotional, financial stress. So you could look at it objectively and then look at people actually report, I'm having a lot of problems paying my bill. It's really stressing me out. Also information about, you feel that you're locked into a job since you can't retire, even though you would like to. And job satisfaction. And all of that is in the biannual interview in the psychosocial, which is a sort of, they call it a left behind. I hate that term. But after a 2.5-hour in-person interview or telephone interview, no, it doesn't go out to the telephone people. It only goes to the in-person. The interviewer leaves a questionnaire behind, and the people are asked to complete it in their own time and given a standard addressed return and envelope. Anyway, here's the website for RAND, and you'll be able to see all these links in the PDF file, which will be in your resources. How about family and social connections? Well, there's obviously the number of people who live in a household, whether somebody's married or not, or divorced, all of those sorts of things. But in the psychosocial questionnaire, we have much more in terms of the number of friends and the number of other family members. Also the quality of relationships, which of course is also very important in terms of well-being and emotional well-being. The sorts of positive and negative support that can you rely on your spouse to give you help in times of crisis, or are they a pain in the neck and you cannot rely on them? How close do you feel to your spouse? How much time do you actually spend together? Is it enjoyable or not? It's all very telling, and don't forget that they're both members of a household complete this. So you can actually compare. Does one partner say one thing? Does the other partner say something different? And how about your children? Well, children sometimes also get, very loving and love you, help you a lot. But maybe, they, at some point in time, they're not that way, and they're giving, they're criticizing you a lot all the time. So that's more the negative support. How often do you see them? How often do you telephone or email or Skype or something? And this sorts of contact. Also with other kin, siblings, parents, for example, if they're still alive, parents-in-law, and friends. We know that friends often give much more positive support and a sense of well-being. And on the other side, of course, loneliness, a sort of perceived lack of social connection. Okay, moving right along. I could spend a whole hour just on one of these circles, right? Now looking at the personal characteristics, I think you've also heard about Midas. So we have the big 5 personality characteristics. Conscientiousness might be related to not going into debt, for example. Neuroticism is feeling tense about things, so worrying about debt, for example. Cynical hostility, it's a very interesting variable in terms of feeling like it doesn't matter what I say, nobody's going to care about it anyway idea. Lots of measures in terms of ongoing chronic stresses, in terms of caring for a sick family member, recent life events, long-term traumas, self-related beliefs. This is really probably what you're calling coping. I call it, some different disciplines call it very different things. It's a feeling that you have control over your life, or a sense of agency or self-efficacy. Also in different domains of life. So do you have control over your health, your wealth, your work, your finances, your social relationships, versus a sense of hopelessness? I don't have that sort of control. Feeling optimistic or pessimistic. How old you feel, or what age you actually feel, very interesting. Data, perceptions of aging, for example. Attitudes about risk. So some people are prepared to take risk about their finances, but not about their health, or risks about driving, but not about other things. And fears or concerns about aging. Obviously, we have many older people, and that's also an interesting aspect in terms of if you're fearing about being a burden on somebody. Do you take some sort of preventative health aspects? Lots and lots of things about lifestyle and work, perceptions about where you live, spirituality, religiosity, everyday discrimination. This is a sort of standard measure that's used by many people, and the attributions for that discrimination, whether it be by race and ethnicity, gender, age, for example, is a big one. Physical appearance. We're adding much more now about the use of lots of modern devices, social media, all of these sorts of things. And also these sorts of self-perceptions about your perceived ability to work. Maybe you're unemployed and you'd like to be able to work because you think you can. And job satisfaction. And all of this is in the psychosocial user guide, very detailed descriptions of where all these measures came from and how to use them. We have oodles of health data as well, self-reported diagnosed conditions, whether it's being treated, mobility limitations, IADL, ADL, these are functional limitations. Standard ones, cognition, it's actually an objective assessment of memory performance, fluency, reasoning ability, cognitive impairment. These are all in the public data. These biomarkers are also in the public data. It's a sort of imputed cognitive functioning measures so that you don't have to calculate them all yourself. And that will give you a sort of different levels of normal cognitive functioning, moving into some sort of cognitive impairment versus suspected dementia. There are polygenic risk scores that are also in the public data for many different aspects, longevity, cognitive functioning, these sorts of things. So you don't have to register with dbGaP to get the sort of particular genetic SNPs. So you could use these polygenic risk scores. Many people are starting to do that. Epigenetic clocks, this is like the rate at which you are aging. Maybe if you're under a lot of stress, the idea would be that you're aging at a faster rate genetically or biologically than your actual chronological age, or you're much younger. Also, it's an interesting new development in this epigenetic idea, the idea that environment interacts with the your genome, each person's genome, and leaves a mark. Stress, for example, might leave a mark, an epigenetic mark, in terms of just changing the expression of some, upgrading the expression of some particular genes and downgrading others. This is all in the public data. And you can also apply for sensitive or restricted data. Restricted data has to be analyzed within a data enclave. Okay. Demographics, we have a lot of those too. Obviously, age, birth year, self-reported sex or gender, marital status, race, ethnicity, years of education, also geographical location, obviously, because we visit people. We don't give out those addresses or zip codes, but it is coded so that you could look at whether the population density of where somebody lives and the different census regions or the regions of US. So if they're living down south or up more north, those sorts of things. Rural versus city. Okay, now emotional well-being. We have a lot of information about emotional well-being. And I added together I put it all together as well-being. So obviously life satisfaction, domain-specific satisfaction with your family, the housing, where you live, the activities in your life. How about emotional well-being? I know this network is trying to define what on earth emotional well-being is, right? So we have a measure of positive and negative affect. This is the so-called PANAS measure. We have expanded PANAS. So I think it's 10 different adjectives describing positive and 10 or more describing negative affect. We have psychological well-being, in particular, a sense of purpose in life, which I think is a very important one in terms of sort of your motivation you feel like you're useful and doing things. We added in day reconstruction. So these measures are life satisfaction is the life right now, that's looking back. In general, the emotional well-being measures are usually over the last month. It's a sort of somewhat of a trait-like measure. Day reconstruction is, how was your day yesterday? With the idea from Danny Kahneman and others that maybe people actually remember yesterday and they can tell us, what they did, how they used their time, and how they felt during different activities. So it also, like, how well did you sleep yesterday? What time how long did you sleep? What time did you go to bed? What time did you wake up? How did you rate your health yesterday? Was it a usual day, or did you have lots of hassles, which might mean that you experienced a lot of negative affect yesterday, for example. So this is within the psychosocial questionnaire. We also have measures of financial well-being. This is perceived financial well-being, and a self-reported, do you feel like you don't have a lot of money left by the end of the month? And all of this is described in the user guide. Okay. All right. And if you want to look at lack of well-being, of course, we have indicators for depression as well, both a 12-month episode of major depression, but also like the depressive symptoms from the CESD. Now you have to take care with these because, and you'll see in the literature, a lot of people over the years before the big psychosocial battery, they use single measures of these, single items, but that's not really what they're meant to be used for. So, and depressive symptoms also go with health and people experiencing a lot of pain from arthritis and that sort of stuff. Okay, now we're getting into where on earth could I access all these data and how do I actually do it? Okay, so this is the website for HRS. I don't know if anyone's listening along, or you can look back and listen to this recording again and follow along. When you enter, they just change the photo, so don't be scared if you would go to this website and you see a different photo. They're playing around with the opening page. But there's a lot of information here. So if you start with the opening side and you really sort of need to scroll down for bits and pieces of information right now, it's probably going to be optimized to use on a laptop or an iPad. Lots of introductory information. And then you go from there and using I go back again. So there's this, I'm going across the menu bar, right? And each one you can pull down the documentation. And this is all the information that you'll find linked here. And then I've been talking about user guides. I really recommend that you check out these you don't have to register, they're just free. Just go to the website, you can download as many user guides as you want. And there are also video tutorials that have been put up over the years, and webinars, and they're sort of added to along the way, but I recommend starting here just to get a sense. And then you can also look at all the different questionnaires in each section, and also what we call code books. So the code books of how the information is actually coded in the data are all linked here. This is all just on the website. The user guides, now I'm still in documentation. User guides, there are set general ones, some for cognition, economics, employment at work, family, health, life history, methods, psychosocial and well-being, and then there's an archive because the user guides are updated along the way, especially as we start to add more and more information. Questionnaires, now I'm still on the bar, so already the questionnaires for 2022 are available, and then you can go down and sort of look at, so what do we ask about demographics? What questions do we ask about health status? All of these sorts of things. And it goes all the way back to 1992. And this is just the name of the section. Okay, so I'll leave you to scroll through that and explore that page because I can't show it all to you all at once. Okay, so I tried to do a sort of flow chart of maybe how you would start accessing these data and putting your samples together. So first of all, you register as a user. You don't have to register just to look and explore all the website, right? You don't have to register. But if you want to have some data, you do have to register. And that's pretty easy. You just put in your name, your email, read the conditions of use. That just means, you know, you're not going to like try to identify somebody in the sample or something like that. And after you've registered, first of all, I'd say, of course, you could just go ahead and download as much data as you want, but I don't recommend that because it's a lot of different files. So decide what you need. Do you only need one wave or two? Maybe start simple. What variables do you need? Which section are they in, right? And then download those. And I always suggest to people just start simple and expand later on. Every file that you download always include HHID, that's the household ID, and PN, the person number in the household. That's what you need to be able to merge together different data files. So start with the so-called cross-wave tracker. I'm going to show you that now. This just tracks households and people since 1992. You have to do a bit of housekeeping. We put out the data, but the labels for each number are not defined. So you need to sort of do a bit of housekeeping by referring to the code books, which are all on the website, about what a number actually means. Does a 1 mean a yes? Yes, it does. And a 5 typically means a no. And if you don't want it that way, then you have to recode it. If you want yes to be a higher number in your analysis, for example. And then you can start downloading the data from the sections that you want. But remember to include HHID and PN. And then you merge together these separate data files, right? Okay. Now I'm back to that menu bar, remember? So the data products, the conditions of use are over there. That was step 1. Step 2 was registering, and the public data, we'll go through that. And there's lots of other ones, but I think you just want to start here, right? Here's the conditions of use. It's not really very much. And we do it when you're publishing, then we do ask you to at least put in the text that you're using HRS data. And this is how you reference it in your citation list, right? We need that because we have to, or NIA, of course, wants to see how many people are actually using these data because they spend a lot of money on. Okay, the tracker file, I've mentioned that before. So this is like where you're going to get all of your demographics, and it's called a cross-wave tracker file. It's in data products, and it's the public survey data. If you want RAND data, you can click on over here on the menu bar and collect that. This is what the code books look like. So let's take a look at the code books for the cross-wave tracker file. Remember I mentioned CAMS, that consumption mail survey. That's where you could pick up all of that data. Okay, HHID PN. Remember, it's always at the top of every file, and this is like an early release. We put out an early file, and then the HRS staff sort of check for anything, and then it might take them a year to check it, but and then they put out a so-called late file. But you can just go ahead, use the early file. There's usually not very many changes. And here you can see this is like the 43,559 households. So this file will have information or missing information for that number of households. And here's the person number, which just means we start off with 01, which was the initial target person. 02 was the partner or spouse. And then, of course, people break up into different households, and they bring in new partners, but we keep on following everybody. even if they split. And then you can go down and look at all of the different variables that you want. But this is where gender, if they're Hispanic or not, race, ethnicity, number of school years, if they're born in the US, and lots of other pieces of information. Code books. So this is the complete data for HRS. And remember, I told you about different sections. So the physical health is in C, cognition is in D, functional limitations in G, lots of things in terms of housing, employment, pension, retirement, all of these sorts of things, different sections. And the psychosocial is called LB because I said it's a left behind at the end of people answering all of those other things, right? And this is when you click on the code book for the leave behind, and you can see it starts off with HHRDPN. So that's how you would merge it together. And then you can go through and look at, were they eligible or not? Did they complete it? And then it goes through each item. So to find out each item, what it means, then you go to the user guide. Along the way. So, and more information about all the different sorts of things. So I think we talked about satisfied with life, for example. This is a 5-item measure, the so-called DINA, satisfaction with life scale. And this is starting off, do you live with a spouse or partner, yes or no? And then does the spouse understand the way that you feel? Can you rely on them for a serious problem? This is sort of the quality of support. Do they get on your nerves? How close are you? Do you spend enjoyable time together? Okay, here's a lot of other very useful resources. So again, you don't have to register for any of these, or well, you do to access the data enclave. You can actually link HRS data to Medicare data, but this is in restricted, and you need to have access to that in a data enclave. The RAND file has a lot of good imputed variables for economics and income and wealth and those sorts of things. We run workshops, and if you're just getting into it and you want to learn much more, I fully recommend the summer introduction workshops. We hold them here in ISR. I mean, they were remote for a while, but it's usually 1 week, and you really get a really excellent introduction to it. And then in December, each December now, there's a sort of web version that follows up on specific topics. And we have a help desk. And so you can submit, if you're starting and you get stuck and you don't know what to do, just either email this email and someone will send you a response and be in touch with you and help you along, or you can also submit it online. Okay, that's all. So if you have any questions left after all of that, I know it's like a lot of information, right? But I'm happy to answer some questions if you like.